Beta blockers in hypertension. These drugs are beta-adrenergic antagonists, meaning they block the binding of adrenaline and noradrenaline to beta receptors. By preventing sympathetic stimulation, they reduce heart rate, decrease the force of cardiac contraction, and suppress renin release from the kidneys. Together, these effects lower blood pressure. Although they are no longer first-line therapy for uncomplicated hypertension, beta blockers remain a cornerstone of antihypertensive therapy in patients with conditions such as coronary artery disease, heart failure, or certain cardiac arrhythmias. Mechanism of action. Beta blockers lower blood pressure primarily by blocking beta-1 adrenergic receptors in the heart and kidneys through four key pathways. First, they reduce cardiac output by decreasing both heart rate, called the chronotropic effect, and the force of contraction, known as the inotropic effect. Second, they decrease renin release, suppressing the renin-angiotensin aldosterone system, which reduces the formation of angiotensin 2 and aldosterone. Some agents like propranolol also produce central inhibition by reducing sympathetic outflow from the CNS. Finally, newer agents such as carvedilol and nebivolol also reduce peripheral resistance, further contributing to blood pressure control. Therapeutic uses. Beta blockers are indicated in hypertension across several specific clinical scenarios. Clinical indications. Although beta blockers are no longer first-line drugs for uncomplicated hypertension, they have several important clinical indications. They improve survival in heart failure, particularly metoprolol, bisoprolol, and carvedilol. Following myocardial infarction, they reduce mortality and the risk of reinfarction. In ischemic heart disease, they lower myocardial oxygen demand while controlling blood pressure. They are especially effective in young hypertensives with high sympathetic activity and are also useful in tachyarrhythmias, where they control both elevated heart rate and hypertension. Adverse effects. The most common is bradycardia due to excessive slowing of the heart rate. They should not be stopped abruptly, as sudden withdrawal may cause a rebound effect leading to rebound hypertension or tachycardia. Bronchospasm is another important adverse effect, particularly with non-selective agents such as propranolol, making them unsuitable for patients with asthma. Finally, beta blockers may mask hypoglycemia, blunting its warning symptoms in diabetic patients receiving insulin or sulfonylureas. Other side effects. Beta blockers can also produce several other side effects. Some patients experience fatigue and sleep disturbances, particularly during the initial weeks of therapy. They may also develop cold extremities because reduced peripheral circulation decreases blood flow to the hands and feet. Selective versus non-selective agents. Beta blockers are classified into selective and non-selective agents based on their receptor selectivity. Selective beta-1 blockers such as metoprolol, bisoprolol, and atenolol primarily act on the heart, making them safer in asthma and generally preferred in diabetes. In contrast, non-selective beta-1 plus beta-2 blockers such as propranolol also block beta-2 receptors in the lungs, increasing the risk of bronchospasm and masking hypoglycemia. Newer third-generation agents provide additional vasodilation through alpha-1 blockade, offering broader hemodynamic benefit. Key prescribing considerations. Let's conclude with some key prescribing considerations for beta blockers. They are preferred in patients with heart failure, post-MI, ischemic heart disease, and tachyarrhythmias, where they provide benefits beyond blood pressure control, including improved survival and reduced cardiac workload. However, They should be used with caution in diabetes, asthma, and COPD. In these patients, selective or third generation agents are generally preferred because they have a lower risk of bronchospasm and metabolic adverse effects. Finally, never stop beta blockers abruptly. Always taper the dose gradually to prevent rebound cardiovascular effects such as severe hypertension, tachycardia, or angina. These precautions help ensure safe and effective use of beta blockers in clinical practice.